Welcome to this presentation on the evolving impact of cardiovascular outcome trials in type 2 diabetes. In the next few minutes, we will examine how these pivotal studies have transformed our approach to diabetes care, shifting the focus from glucose control alone to broader concerns such as cardiovascular safety, treatment strategies, and regulatory standards. Whether you're a clinician, researcher, or educator, understanding these trials is essential to advancing patient care. So let's start by tracing the development of CVOTs and exploring their significance in modern diabetes management. Cardiovascular outcome studies or CVOTs in diabetes can be grouped into three main categories. The first on your left focuses on glucose control alone, comparing intensive versus conventional strategies as shown in landmark trials such as DCCT in type 1 diabetes, UKPDS, ACCORD, ADVANCE, and VADT in type 2 diabetes. The second examined treatment strategies in the middle, exemplified by Barry 2D trial, which compared revascularization plus intensive medical therapy against optimal medical therapy alone, using either insulin sensitizing agents like metformin or thiazolidinedione or insulin providing agents such as insulin or sulfonylureas. A similar design was used in Courage trial, which investigated VCI plus optimal medical therapy versus optimal medical therapy alone, regardless of diabetes status. The third category on your right emphasizes the cardiovascular safety of a newer antidiabetic agents, acknowledging that although these drugs can effectively lower blood glucose, the molecules themselves may also exert off-target effects that influence CV risk. This was the central reason why, in December 2008, the US FDA mandated long-term cardiovascular outcome trials or CVOTs for all newly developed type 2 diabetes therapies, a requirement that broadened the scope and cost of drug development while setting regulatory standards for cardiovascular safety data specific to each agent. Now, let me take you through the phases of clinical trials, as their framework was notably reshaped following the US FDA 2008 mandate requiring cardiovascular outcome trials for all new antidiabetic drugs, a point we will revisit later. Now, this diagram outlines the sequential stages of drug development, beginning with the preclinical studies in the laboratory and animal models to evaluate basic safety and biological activity. Phase 1 trials then enroll a small group of healthy volunteers, usually just a few dozen, to assess safety, tolerability, and pharmacokinetics. Phase 2 trials expand to several hundreds participants, aiming to define the optimal dosing range and collect preliminary evidence of efficacy while continuing to monitor safety. Phase 3 trials involve thousands of patients and are designed to confirm efficacy, detect adverse effects, and compare the new therapy against standard treatments across diverse populations. And finally, Phase 4 trials consist of a post-marketing surveillance where long-term safety, rare adverse events, and real-world effectiveness are evaluated after regulatory approval. This phased approach ensures that every new therapy undergoes rigorous testing for both safety and efficacy before being integrated into clinical practice. Now we turn to the early cardiovascular outcome trials in diabetes, studies that shape our understandings of intensive glycemic control and establish the foundation for today's evidence-based clinical practice. This chart summarizes 5 landmark trials: DCCT/EDIC, UKPDS, the initial trial, and the long-term follow-up. The ACCORD, ADVANCE, and VADT highlighting the impact of intensive glycemic therapy on HbA1c, microvascular outcomes, cardiovascular disease, and mortality. In both DCCT, EDIC, and UKPDS, intensive therapy achieving substantial reduction of A1C, targeting A1C of less than 7%, and significantly lowered microvascular complication during the initial trial period. However, cardiovascular and mortality benefits were not evident until long-term follow-up, where both trials showed clear reduction in cardiovascular events and death. This delayed benefit is known as the legacy effect, the idea that early sustained glycemic control confers long-term macrovascular protection even after HbA1c different diminishes. In contrast, ACCORD, ADVANCE, and VADT enrolled patients with longer-standing diabetes and higher CV risk. These trials aim for more aggressive HbA1c target, around 6.5%, but showed mixed cardiovascular results. While microvascular outcomes improve consistently, cardiovascular benefits are less predictable. Notably, ACCORD reported increased mortality in the intensive group, likely due to rapid glucose lowering in a vulnerable population. Overall, the evidence reveals a key distinction. Intensive glycemic control reliably reduces microvascular complication, a straightforward relationship, but its impact on macrovascular outcomes is more complex, depends on the timing, patient profile, and duration of follow-up. Now, the legacy effect reinforces the importance of initiating tight glucose control early in the disease course to achieve long-term cardiovascular benefit, while cautions against overly aggressive strategies in high-risk late-stage patients. So, in summary, as far as glucose control alone studies, in the early glucose-centric era, diabetes care focused almost entirely on lowering A1C, which reliably improved microvascular outcome but had inconsistent effects on cardiovascular disease. Over time, we learned that macrovascular risk is far more complex and not fully addressed by glucose control alone. Now again, the legacy effect from UKPDS and DCCT showed that early intensive control can translate into a long-term cardiovascular benefit, but later trials like ACCORD, ADVANCE, and VADT made it clear that aggressive glucose lowering in high-risk, long-standing diabetes does not improve cardiovascular outcome and may even cause harm. This insight marked a major turning point, shifting the field away from A1C only targets towards therapies that provide direct cardiovascular protections. The clinical lessons and implications for managing cardiometabolic risk beyond glucose lowering. Number 1, trials such as Barry 2D and Courage demonstrate that revascularization approaches provide no significant advantage over optimal medical therapy in a stable ischemic heart disease. Number 2, CV outcomes in Barry 2D were unaffected by whether glucose control relied on insulin synthesizing agent or insulin providing approaches. Number 3, comprehensive medical management addressing blood pressure, lipids, lifestyle, and antiplatelet therapy is what truly drives cardiovascular risk reduction. Number 4, in a stable CAD, procedures are insufficient on their own to modify cardiometabolic risk. And lastly, these trials expose the limits of earlier strategies and establish the need for therapies with direct CV benefit, shaping the evolution of modern CVOTs. So as we move beyond the early trials focused solely on glucose lowering, the field of diabetes research has shifted towards evaluating the cardiovascular impact of individual antidiabetic agents. This next phase of investigation centered on whether specific drugs, beyond their glycemic effect, can deliver meaningful cardiovascular protection. These outcome studies are designed not just to confirm CV safety, but to assess whether agents like GLP-1 receptor agonist or SGLT2 inhibitor and others that can reduce major adverse cardiovascular event in high-risk population. This approach reflects a broader therapeutic goal targeting both metabolic control and cardiovascular outcomes through drug-specific mechanism. Now we go now to ICH guideline before 2008. ICH stands for the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use. The ICH's role is to ensure that safe, effective, and high-quality medicines are developed and registered in the most resource-efficient manner. The guideline before 2008, you simply had to show in 1,500 patient pharmacokinetic and pharmacodynamic data and only have to treat 300 to 600 per 6 months and only 100 patients to be exposed for a year of a glucose-lowering medication. Now, this is a medication intended for use for patients with a lifetime disease. And so we were bringing drugs regularly to the market with as little as 250 patient years of observation. Now, this impedes the ability to detect important signals or even rare but serious adverse complications that may be caused by the drug related to or unrelated to their intended mechanism of action. Before 2008, diabetes drugs approval under ICH guideline require relatively limited patient exposure. This means that the drugs intended for lifelong use could reach the market with as little as 250 patient years of observation. However, rare but serious adverse reactions often require much larger exposure to be detected. Examples such as taspoglutide, aliglitazar, and falsiglifam all developed but not approved because it revealed important safety signals, including antibody formation, heart failure, kidney decline, fractures, GI bleeding, and liver injury, only after thousands of patients' years of data. These experiences highlighted the limitation of earlier approval standards and drove the shift towards larger cardiovascular outcome trials and long-term safety monitoring in diabetes drug development. One of the most significant and widely discussed issues before the US FDA established its position was the case of rosiglitazone. As a PPAR gamma agonist, rosiglitazone was developed to improve insulin sensitivity and address insulin resistance. The critical question, however, was whether this mechanism could also translate into reduction in CV event. While ongoing trials were underway, a meta-analysis pooling data on rosiglitazone unexpectedly suggested an increased risk of myocardial infarction. Now, although meta-analyses are hypothesis generating rather than definitive, this finding raised serious concern about the CV safety of individual glucose-lowering drugs. This was particularly important in diabetes, where patients already face elevated CV risk, and introducing a therapy that might further increase that risk would be unacceptable. Now, concern about CV safety in glucose-lowering therapies have a long history, beginning with the UGDP study in 1961, which led to the discontinuation of tolbutamide due to increased CV mortality. Over the decades, additional safety signals emerged. Miraglitazar in 2005 raised concern during FDA review, and as mentioned earlier, rosiglitazone in 2007 was linked to an increase in myocardial infarction and even cardiovascular death, prompting withdrawal in Europe and restricted use in the US in 2008. The ACCORD trial added further urgency by showing increased all-cause mortality with intensive glucose lowering. These cumulative events led the FDA in 2008, and the EMA in 2012 to mandate that all new glucose-lowering drugs for type 2 diabetes must demonstrate cardiovascular safety through meta-analysis and dedicated cardiovascular outcome trial. This marked a pivotal shift in regulatory expectation, prioritizing long-term safety in the population already at elevated CV risk. In 2008, as mentioned, the FDA issued guidance requiring all new anti-hyperglycemic agents to undergo CV safety assessment through randomized controlled trials. These trials were designed primarily as non-inferiority studies aiming to show that the drug did not increase the risk for major adverse cardiovascular event known as MACE compared to placebo. If non-inferiority was confirmed, some trials proceed to test for superiority. The standard primary endpoint was a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. Although some trials included additional components, this regulatory shift laid the foundation for the modern era of cardiovascular outcome trials in diabetes. Cardiovascular outcome trials or CVOTs assess both safety and potential benefit of anti-hyperglycemic agent using two key statistical benchmarks, the non-inferiority and superiority. The drug is considered non-inferior if it does not increase the risk of major adverse cardiovascular event known as MACE compared to placebo. This is statistically confirmed when the upper limits of confidence interval remains below a predefined threshold, typically 1.3. Once non-inferiority is established, some trials proceed to test for superiority, which requires the upper bound to fall below 1, indicating that the drug not only avoids harm but actually reduces cardiovascular event. So far, all tested diabetes medication have met non-inferiority standards, confirming their cardiovascular safety. However, not all have shown superiority by significantly lowering cardiovascular risk. Now let me explain how the FDA cardiovascular outcome trial requirement transform phase 2 and phase 3 clinical trial design. The FDA now requires all new diabetes medications to prove cardiovascular safety before they will be approved. As the result, phase 2-3 trials must be built to support a cardiovascular meta-analysis, which include enrolling high-risk patients and using blinded adjudications of cardiovascular event. Each investigational drug must generate at least 2 years of exposure and roughly 15,000 patient year of data, and the pooled results must demonstrate non-inferiority for major cardiovascular event before marketing. The inserts image on your right is the pre-marketing analysis typically required around 122 events to show that the upper bound of the 95% confidence interval remained below 1.8 for a hazard ratio of 1, a reflection of the smaller sample sizes involved. In contrast, post-marketing analysis supported by larger event counts of approximately 611 yield narrower confidence interval with an upper bound falling below 1.3, offering greater statistical precision. This illustrates how post-approval data can sharpen risk estimates and reinforce safety conclusions with greater statistical confidence. Now, this timeline outlined the progression of FDA-mandated cardiovascular outcome trials for anti-diabetic therapies from 2013 to 2025. Initial studies involving DPP-4 inhibitor demonstrated cardiovascular neutrality, fulfilling regulatory safety requirements. The pivotal shift occurred in 2015 with EMPA-REG outcome establishing empaglifloxacine's cardiovascular benefit and redefining therapeutic expectation. Subsequent trials with GLP-1 receptor agonists such as LEADER, SUSTAIN 6, and REWIND confirmed consistent reduction in major adverse cardiovascular event. SGLT2 inhibitors further expanded the evidence base, notably through CANVAS and declared TIMI 58, highlighting benefits in heart failure and renal outcome. The timeline culminate in the next generation CVOTs, SOUL, the oral semaglutide in 2024, and SURPASS CVOT, tirzepatide, in 2025, making the continued evolution of glucose-lowering therapies under rigorous cardiovascular scrutiny. In effect, the FDA 2008 CVOT mandate has transformed diabetes drug development, shifting the paradigm from glycemic efficacy alone to integrated cardiovascular safety as well as benefit. CVOTs in diabetes are designed primarily to establish cardiovascular safety using 3-point MACE as the key endpoint and requiring at least non-inferiority to standard care. Secondary outcomes such as renal endpoints or hospitalization for heart failure are exploratory, and any promising signals typically need confirmation in a dedicated trials. This structure ensures rigorous cardiovascular safety assessment while still allowing investigators to identify and further study potential benefits beyond glucose lowering. Now, we now go to the DPP-4 inhibitors CVOT studies. Now, these slides compare the major DPP-4 inhibitors cardiovascular outcome trials conducted under the FDA 2008 safety mandate across SABRE, EXAMINE, TICOS, CARMELINA, and CAROLINA. The class consistently showed cardiovascular neutrality with hazard ratio near 1 and no signals of increased risk. Despite differences in the design and follow-up, all trials confirmed non-inferiority on 3-point MACE, and Carolina further demonstrated safety versus sulfonylureas. So overall, DPP-4 inhibitors are cardiovascularly safe but lack the protective benefits seen with SGLT2 and with GLP-1RA. Now, this forest plot represents cardiovascular safety data from 4 major CVOTs of DPP-4 inhibitors. On your left, all 4 agents demonstrated CV safety on a 3-point MACE endpoint. On your right, however, the secondary outcome of hospitalization for heart failure shows important differences. In saxagliptin, SABRE-TIMI 53 was linked to a statistically significant increase in heart failure risk, while alogliptin in EXAMINE show a non-significant upward trend. In contrast, sitagliptin and linagliptin maintain a cardiovascular safety without any signal for heart failure harm. Collectively, these findings affirm that while DPP-4 inhibitors meet CV safety threshold for MACE, individual agent may differ in their heart failure signal. When we look at SGLT2 in meta-analysis across 5 major trials, they reduce major cardiovascular events like heart attack and stroke by 10% and lowered the risk of cardiovascular death by 15%. These results were consistent across different studies and patients group, confirming that SGLT2 inhibitors offer real heart protection, not just safety, for people with type 2 diabetes. Now, hospitalization for heart failure consistently emerges as the meaningful secondary benefit of SGLT2 inhibitors. A pooled meta-analysis showed a hazard ratio of 0.68, reflecting a 32% reduction in heart failure hospitalization with no heterogeneity, confirming the robustness of this effect. Across all 5 major trials, EMPA, REG, Outcome, CANVAS, declared TIMI 58, Credence, and Vertis CV, SGLT2 inhibitors reliably lower the risk of heart failure hospitalization compared with placebo. Taken together, these findings establish hospitalization for heart failure reduction as a reproducible and clinically important secondary benefit of SGLT2 inhibitor class. Now, in terms of overall kidney outcome, this meta-analysis showed that SGLT2 inhibitors also consistently protect the kidney in people with type 2 diabetes. Across 5 major trials, they reduced risk of kidney disease progression by 38%, with strong benefits seen in DECLARED and CREDENCE. These results confirm that SGLT2 inhibitors are not just for blood sugar control, they also show or slow diabetic kidney disease, especially in patients with albuminuria or high cardiovascular risk. Meta-analysis show that GLP-1RA reduced MACE event by about 14% with benefits seen in patients both with and without established CVD. Several but not all CVOTs demonstrated significant MACE reduction. On this slide, 5 of the 8 trials met the primary endpoint. Rewind is notably because dulaglutide reduced MACE even in a largely primary prevention population, supporting its approval for both primary and secondary prevention. In contrast, ELIXA, EXCEL, and Pioneer 6 did not show cardiovascular benefit. Albiglutide and ephiglinitide were studied but never commercialized, although ephiglinitide showed reduction in MI, stroke, CV death, and slower kidney function decline in newer analysis. The latest CVOT data disclosed for incretin-based therapies, number 1, SOUL, provided the first clear cardiovascular outcome evidence for an oral GLP-1RA showing a 14% reduction in MACE. The SURPASS CVOT was the first head-to-head CVOT comparing a dual GIP and a GLP-1 agonist with a GLP-1RA, demonstrating non-inferiority to dulaglutide with added benefits in mortality, weight, glycemic control, and renal signals. The GLP-1 RA CVOTs varied in cardiovascular risk profile of their participants. Trials like ELIXA and Harmony enrolled 100% of patients with established CVD, while LEADER, SUSTAIN 6, and EXCELs included 73 to 83% with prior CV events. In contrast, REWIND with dulaglutide had only 31% with prior CV disease, making it the most representative of a primary prevention population. This distinction is crucial for interpreting outcomes and applying trial findings to clinical practice, especially when considering GLP-1 RAs for patients without prior cardiovascular events. GLP-1 RA have demonstrated cardioprotective effect on people with type 2 DEM and established CVD. GLP-1 receptor agonists have been shown to provide CV protection in people with type 2 DM and established CVD, though their benefit vary by agent. Liraglutide, dulaglutide, and semaglutide each demonstrated positive CV outcome but with different areas of strength. In the LEADER trial, liraglutide significantly reduced both 3-point MACE and CV death, with its benefit largely driven with fewer CV death. In the REWIND trial, dulaglutide lowered 3-point MACE mainly through a reduction in non-fatal stroke, while CV death and non-fatal MI were not significantly improved. In the SUSTAIN 6 trial, semaglutide also reduced 3-point MACE and non-fatal stroke, though it did not significantly affect CV death and non-fatal MI, with its benefit likewise driven by stroke reduction. So overall, these findings emphasize that while all 3 GLP-1 receptor agonists confer cardioprotection, liraglutide is the most effective in reducing CV death, whereas dulaglutide and semaglutide are more impactful in lowering stroke risk. Now, the clinical implication is that GLP-1 therapies consistently provide CV protection in type 2 diabetes, though their strength differ. Liraglutide, as shown in LEADER trial, is most effective in reducing CV death. Dulaglutide in the REWIND trial lowers stroke risk in a broad population, while semaglutide in SUSTAIN 6 demonstrates similar stroke benefit in high-risk patients. More recently, the SOUL trial confirmed that oral semaglutide reduced major adverse cardiovascular event by about 14% in patients with atherosclerotic cardiovascular disease or CKD, extending protection to diverse high-risk groups. Finally, the SURPASS CVOT trials showed tirzepatide was non-inferior to dulaglutide in reducing MACE while offering superior improvement in glycemic control, weight, renal outcome, and all-cause mortality. Together, these findings highlight that GLP-1 receptor agonists provide cardioprotection across injectable and oral formulation, and tirzepatide may represent the next step in integrated cardiometabolic care. So in summary, the cardiovascular outcome trials have reshaped how we treat diabetes. The FDA mandate pushed us to prove cardiovascular safety, and that opened the door to major discoveries. DPP-4 inhibitors showed neutral cardiovascular effects, while SGLT2 inhibitors delivered powerful reduction in cardiovascular death, heart failure, hospitalization, and kidney disease progression, even in people without diabetes. GLP-1 receptor agonists added clear benefit in cardiovascular death and stroke, and tirzepatide brought superior metabolic and renal outcome with confirmed CV safety. We also learned that every signals for heart failure and renal protection first appeared as a secondary outcomes, and this needed and later received confirmation in dedicated heart failure and CKD trials. All of this evidence shifted guidelines towards risk-based therapy and highlighted that modern diabetes drugs protect the heart, kidney, and vasculature, not just glucose. This is the new landscape of cardiometabolic care. And with that note, I'd like to close my presentation and thank you for listening.